factors contributing to periodontal disease. So you've probably noticed when we talk about periodontal disease, we talk about a lot about bacteria, host response, the two things you have to have. And then a big part of it is things that add to or make periodontal disease worse. Systemic diseases, local risk factors, anything that makes habits, anything that makes periodontal disease worse than or alters its course of plan or treatment, we study very heavily. So local contributing factors are like intraoral conditions or habits that increase the susceptibility to periodontal infection. These local contributing factors, the thing to know about them, or the main thing, is they do not initiate disease. The main thing that initiates periodontal disease is bacteria. Bacteria, plaque, biofilm. Anytime you see bacteria, plaque, biofilm as a choice of answer, it's probably going to be the answer.
Mr. Franklin?
Yes?
Could you make the screen bigger for your PowerPoint?
Like the slideshow?
Yeah.
Like that?
Yep, thanks.
Oh, I do know how to do it. Okay. So local contributing factors do not initiate the disease. You have to already have the biofilm. Okay, so this is where I get messed up then, because there's people like trying to join the meeting, and when I flip screens, this is always where I get myself mixed up. So
I don't know if anybody else can do it, but like I keep getting notifications when somebody needs to get into the meeting, so I can click admit. I don't know if anybody else sees it too.
I get them too.
Okay, so you guys could do that? All right.
Yeah.
Perfect. So now can you see the, oops, can you see the screen again?
Yeah, it's up there.
Okay. Jeez. Okay, so the local contributing factors contribute to the disease process. They don't initiate the disease process. You have to have the plaque biofilm present, and you have to have the host response to the plaque biofilm to have disease. Disease sites. What is a disease site? It's an individual tooth or a specific surface of the tooth that is experiencing disease. So factors that increase plaque retention, such as rough restorations, calculus, any kind of removable partial orthodontic bands or brackets, they can all create a surface that retains plaque. And factors that can inflict damage to the periodontium include occlusal trauma, frenum attachments, traumatic toothbrushing. So these are actually things that that you do or that happen that cause damage directly to the periodontium. Occlusal trauma is one that you're going to see a lot of. So patients that clench or grind their teeth. Sometimes patients just have like a really hard bite. If their teeth are in crossbite, or they have an edge-to-edge or end-to-end bite, those kinds of things inflict damage on the periodontium. Nature has a way that that teeth are supposed to meet each other and work together, and when they don't, you can have damage caused to the periodontium from them not being properly aligned. So biofilm retention, calculus is one of the biggest culprits of biofilm retention. So bacteria plaque, biofilm sticks to the teeth. Over time, it mineralizes and it turns from plaque to calculus. So calculus is really nothing more than mineralized plaque. But then what happens is calculus has like a rough, porous surface. And so plaque and biofilm and bacteria can stick to calculus better because it's not smooth. It's got like a rough surface, so it manages to hold. And it's an extremely bad situation because the plaque biofilm is closer to the inside of the pocket or against the tissue when it's pushed out by being attached to calculus. So it makes it even a worse condition. and it's actual just bacteria that sticks to the calculus. And mineralization of plaque biofilm begins from 48 hours up to 2 weeks after plaque biofilm formation. So plaque forms on the teeth and it mineralizes over anywhere between 48 hours and 2 weeks to become calculus. And so during that time, I mean, everybody's a little bit different. And so you'll get patients that, in 4 days, they've got calculus on their teeth again. And then you've got patients that hardly ever have calculus on their teeth, or it takes, it's very slow to form and doesn't form a lot. So you're going to have a wide range of patients and how they form calculus. And you call them heavy calculus formers. So when you're talking to the patient, you can say you form calculus really quickly. So we need to maybe do more frequent cleaning visits or whatever, home care aids you're recommending. The effects that calculus have, remember that calculus doesn't initiate the problem. It contributes to, but it doesn't initiate. The surface is irregular and always covered with plaque. So that's one of the effects that calculus has, is it's kind of rough and porous, and it gets covered with plaque. So it holds the bacteria against the tissue. The more calculus buildup, the more areas of plaque biofilm. So as the original plaque biofilm forms along the teeth and it mineralizes, it becomes calculus, and the more calculus you have, the more rough surfaces you have for more biofilm to build up. And it's very difficult, if not impossible, for a patient to clean it. And this is a picture of dental calculus. We've all had a chance probably by now to see a patient that has dental calculus on especially the lingual of their lower incisors. It's similar to this picture. Plaque on calculus is in close proximity to the tissues, so it makes it even more dangerous that way. Doesn't it make you want to just grab your Cavitron when you see something like this? So here's just pictures of calculus on radiographs. So you can see the little, well, they're not little, those are big pieces poking out from away from the tooth surfaces. You've all by now probably seen patients in clinic that have calculus on their radiographs. So what's calculus made of? Calculus is 70 to 90% inorganic. It's primarily calcium phosphate. And then it has smaller portions of calcium carbonate and magnesium phosphate, but it's primarily calcium phosphate. The high content allows calculus to be visible on radiographs. So when you see calculus though on radiographs, two things to keep in mind. One is what you're usually seeing is interproximal. You don't see dental calculus on the facial and lingual surfaces on a radiograph. And the other thing is that the calculus is usually bigger and more dense in reality than what it is on a radiograph. So there's a lot of times that you'll look at a radiograph and you don't see hardly any calculus, or maybe you don't see any at all. But then you look in the patient's mouth and you take your Explorer around and there's calculus all over. So the calculus just isn't big enough or dense enough to show up on the radiograph, but it doesn't mean it's not there on their teeth. And then the other 10 to 30% is organic composition. It includes materials from plaque biofilm, dead epithelial cells, dead white blood cells, and it may also include living bacteria. As calculus ages, the inorganic components change, and newly formed calculus is called bruchite. And then mature but less than 6-month-old is primarily octocalcium phosphate, and older than 6 months old is primarily hydroxyapatite. So those three words you'll need to know. And I know these words will come up again in histology and embryology probably. Calculus can be supragingival or subgingival. By now you know the difference in them. One thing to keep in mind is that when calculus that's supragingival is above the gingival margin, subgingival is below the gingival margin. This has to do with the gingival margin, not the CEJ. So if you have 6 millimeters of recession and you have the root surface is caked with calculus, that is considered supragingival calculus, even though it's on the root, because the gingival margin is down lower. So if it's if you can see it, basically, if it's visible, it's supra. If you can't see it, if it's below the gum line, it's sub. It can be localized or generalized. So supragingival calculus tends to build up on the buccal surfaces of the maxillary molars and the lingual surfaces of the mandibular incisors, basically where your salivary glands open. And then subgingival is not as particular or site specific. It pretty much forms anywhere. The color of calculus varies too. So supragingival calculus is usually like a whitish yellow color, and subgingival calculus is anywhere between yellow to black. Subgingival calculus picks up the blood pigmentation from the tissue that's up against it, and so that's why it gets darker as it ages. Let's see. 3 modes of calculus attachment to the tooth surface. It can attach to pellicle, so you get your teeth cleaned and within minutes to hours, pellicle reforms on the tooth surface. So from that point on, calculus can attach to pellicle. It can attach to tooth irregularities, or in other words, if you have like deep grooves or any kind of like pitting on a tooth, and then attachment by direct contact to the tooth. So let's look at these different things. Attachment to pellicle. Now remember, pellicle is not bacteria. It's not plaque. It's not biofilm. It's proteins. So it's actually bacteria free, but it attracts bacteria. So bacteria, it's what allows bacteria to stick. The most common means of attachment to the enamel surfaces, calculus deposits attached by pellicle are easily removed easily. So those are the ones you can just kind of scrape off really easily. There's not like a tight bond. You don't have to put a lot of pressure on your scalers or anything to get that off. Irregularities in the tooth surface. So if you have cracks in the tooth, you have grooves, things like that. So the deposits are difficult to remove because the deposits laid sheltered in the tooth defects. So it's really hard if you have a little, if you think about the root groove, the mesial root groove on tooth number 5 or tooth number 12, that calculus can hide inside the little groove. And now you have to try and figure out how you're going to get your instrument into that little groove and be able to scrape the calculus out. So it's much harder to remove from root grooves and things like that. The matrix of calculus deposit may interlock with inorganic crystals of the tooth, and deposits are firmly interlocked in the tooth and are difficult to remove. So if the attachment is to the tooth surface, they can be very difficult to remove. Tooth morphology and increased plaque retention. So surface features of the tooth can increase biofilm retention. So if you have grooves, concavities, enamel projections and enamel pearls, I don't know if you've looked at those too closely. We touched on it just a little bit in dental anatomy, but when you get into path, you'll look a little bit more closely at things like the enamel projections and enamel pearls. Malocclusion, dental caries, orthodontic appliances. When they say malocclusion, they mean like teeth that are rotated or overlapping, that are not in perfect alignment. some of you have probably tried to scale teeth that, like particularly lower incisors that overlap, or they're, like this toward each other, that touching each other in weird ways, and you can't find the right scaler to get in there. It's hard to get all the way into the little creases and stuff. So that all adds to how retentive plaque can become. You also can't reach those areas very well with toothbrushing and flossing and all that kind of stuff. So plaque retention from a home standpoint is much increased. Tooth grooves or concavities. These are some pictures of some grooves, developmental grooves. So that first picture on the left is the groove on the lateral incisor that goes along the lingual that runs from the cingulum down the root. It's called the palatogingival groove. And the right side shows you the groove, the deep mesial root groove on the maxillary first premolar. And then these are some pictures of enamel projections and enamel pearls. So imagine, like, particularly the enamel pearl, if that tooth is sitting, it's a maxillary molar. So if you placed that in the mouth, you can imagine that that would be a little bit hard to keep clean around that pearl. And on this slide, the picture on the left shows you, actually they both show you dental caries, rough areas of enamel. So you can see how, like, you've got this indentation or pit where it's decayed, and the decay itself is kind of sticky. So it makes plaque retention really easy in those areas, and then the plaque that's retained in the decayed area continues to release byproducts that continue to cause decay. Crown margins, the picture on the right, crown margins are very popular places to get plaque and to have calculus build up. Orthodontic appliances. Here's a picture of a lingual bar, and you can see all the calculus on those, on the back sides of those teeth. The first picture on the left, it looks like the lingual bar is cemented on all of the teeth. And the picture on the right, it looks like it's bonded only on the canines and just kind of runs along the back of the teeth, both of which are not easy to clean. But obviously the second one would be easier to clean than the picture on the right would be easier to clean than the picture on the left. Dental restorations as local factors. So some dental treatments may contribute to oral disease. Treatment that results in inadvertent adverse outcome is known as an iatrogenic factor. So an iatrogenic factor is treatment that results in an inadvertent adverse outcome. So sometimes you can have things that dentists are placing restorations or orthodontists are placing orthodontic appliances, and they don't intend for them to cause trouble, but they do. Overhanging margins. So an overhanging margin, who are my dental assistants? Anybody? I know we have some dental assistants in here. So one of you dental assistants, explain what an overhanging margin is.
It's just
It's
like
where
when,
we're going to, oh, go ahead.
it's just when a filling goes over the actual restoration where it's supposed to be.
And how does it get there? Like explain the process of placing it. A lot of your classmates have probably never seen a filling placed, and they won't in clinics since we don't place fillings. So how do you
My dentist always used matrix bands, so we didn't have them, but basically it's like if the filling was an occlusal filling and they used too much material and it just went over the edge, and it would cause an overhanging of the filling.
Okay. Anybody want to add anything? Okay. Yeah, so it's basically like a spillover of too much material, and it didn't get removed, and so then it hardens there. When you have overhanging margins on restoration, oftentimes you'll have bone loss in the same area because of the fact that plaque and bacteria build up underneath the overhang, and it's impossible for a patient to clean it. How about open margin and contacts? Does anybody want to explain what those are?
An open margin is just when they don't get the filling close enough to the tooth next to it. So then they get food trapped in there because they have an open margin.
Okay. Open margins can also occur if they, when there's a space between where they prepped the tooth and the margin itself, like interproximally, right? I think that's what you were kind of describing. Yeah. And then open contacts, of course, too, can occur in natural teeth where they don't touch each other, but or if they put two restorations next to each other and they didn't get them close enough. We used to see that all the time in perio. Patients they get like two crowns and they leave an open contact between them. And then the patient's packing food in there and packing food in there and packing food in there. And over time, they end up developing some perio problems there. And then the dentist sends them to the periodontist to fix it. And it's kind of like, well, the only thing that's really going to fix it is to close the open contact. But now we have a perio problem to fix too. But so then you kind of have to find tactful ways to work together to fix the perio problem that developed and replace the restorations without kind of pointing fingers, you know. Orthodontic appliances, that's an obvious one that anybody who's worn braces will know that you can get all kinds of stuff caught around orthodontic appliances. How about poorly designed dental prostheses? So you have a removable partial. The clasps are too close to the gum line, and so they cause problems down along the cervical third of the tooth. Okay, and these are some pictures of what like an overhanging margin looks like, and you can see there's excess restorative material that had gotten spilled over when they were placing or packing the filling. You can see here that they've got a space right here where this all poured over, and they've got probably an open contact here. But this is the main area right here. And you can see where down here, how this density of this bone has changed. It's caused a problem right here, a huge problem. Poorly contoured crowns. You will see this a lot during your time of practice. These crowns were placed so that the margins of the crowns look like they're coming out of the gum. There's a kind of a fine art to placing the margins so that they're at the gum line but not tucked underneath the gum tissue. And oftentimes doctors will push the margin underneath to try and make it look more natural. But as you can see by looking like at the difference between this one and this one, how this gum tissue just looks kind of like it's suffering some chronic irritation from that. The papilla right here looks pretty bulbous. So this area right here is having some issues based on the fact that there's crowns. Same with this picture on the right here. You can see the metal framework underneath. So this is a porcelain fused to metal crown, and you can see the framework. Gum tissue doesn't like that usually, and so ultimately it becomes a problem. These are obviously some poorly designed dental prosthesis. This is a bridge, and you can see how that there's a lot of things wrong with this, but it's causing irritation to the gum tissue based on the way it's placed. I don't know what's going on over here on this side. Looks like maybe some porcelain chipped off or something. Same with this. This was called a cantilever bridge. They try not to do these kinds of bridges anymore. Most traditional bridges, you have just like a regular bridge, you have land on both sides with a bridge spanning from one side land to the other. You have a tooth on both sides and you have a missing tooth in the middle. So the bridge spans from one tooth to the next and fills the space between. And in this space, they a cantilever bridge is they put an extra tooth off of two other crowns, and you can see, like in this case, it fractured or decayed underneath here. A lot of times what that does is when the occlusal force comes down on this cantilevered part, it torques these two teeth and eventually causes either the teeth to fracture, or it can cause abscessing down at the apex, or it can cause both. But they try to avoid using these kinds of bridges. They're not so bad in the anterior if you're trying to like fill an anterior space because you don't use a lot of occlusal force, but they're horrible in the posterior. Inappropriate crown placement. A crown placement of 2 millimeter coronal to alveolar crest is paramount in maintaining gingival health. So if you remember correctly, the alveolar crest sits about 0.5 to 2 millimeters below the CEJ, or apical to the CEJ. So when a doctor's placing a crown, ideally the placement 2 millimeters coronal to the alveolar crest or above the alveolar crest is where you want to be. So you want to have the margin of the crown, and then about 2 millimeters down is the alveolar crest. If the crown margin is closer than 2 millimeters to the alveolar crest, it can result in bone resorption. So the body always wants to maintain that 2 millimeter space. So it's kind of like you keep your distance. Biologic width, that little space from the alveolar crest is called biologic width. So your body wants to maintain a biologic width or a distance from the crown margin to the alveolar crest. If you push the crown down farther and you invade that space and you only have 1 millimeter from the alveolar crest to the crown margin, the alveolar crest will move. In other words, the bone will resorb itself and reestablish that distance. The biologic width violation occurs if the margin of the restoration encroaches upon the zone of soft tissue occupied by the junctional epithelium and connective tissue attachment fibers. So in other words, you've got your picture on a natural tooth, you've got your crown of your tooth, and then you've got your gingiva and your sulcus, and then you've got your junctional epithelium, which is attached right from the on the coronal part of the tooth to the CEJ, and then you've got that space of connective attachment, and then you've got your alveolar crest. And so if you take the crown margin into that space where the junctional epithelium and the connective tissue attachment fibers are, you're going to cause the alveolar crest to move down so that it gives back the space to those fibers. Oftentimes what it results in, let me see if I can find that picture again, is it results in something that looks like this. So they've shoved these crown margins, and what they invaded the biologic width space. So they've pushed the crown margin into where the connective tissue and the junctional epithelium are supposed to sit. So over time, that tissue is going to become irritated. Inflammation's going to set in. Your inflammatory cells are going to keep coming over here, and it's going to turn into a chronic situation. And these cells are going to cause the alveolar bone to be destroyed. And as the alveolar bone gets destroyed and moves down, it allows the space for those fibers to come back. But it stays in a chronic state like this. And so when you have something like this, the only way to resolve this basically is to trim this tissue back up. So there's a surgical procedure called crown lengthening. Now, some of you who worked for general dentists, they did crown lengthening where they just trimmed the tissue, the gum tissue a little bit. Like they would take this and they would trim this dead tissue away. That is not technically what crown lengthening is. Crown lengthening is where you go back underneath, you flap this tissue, and you reestablish the normal architecture of the tooth. So in other words, you would reshape the bone, you would allow for the tissue attachments, and so you would readjust the gum margins, the tissue margins, so that there's enough space, so everybody's happy again. So basically you're recreating the original architecture. It's a much bigger procedure than just cutting off a little bit of tissue. They actually have to take a burr and grind down the bone and move it down a little bit so that that soft tissue has a place to attach itself, and then it'll be happy again. The other option would be to take these crowns off and redo them, which a lot of times doctors don't want to do that. So those are kind of your two choices. But patients, all the time, we would see patients that come in with tissue that looks like this and they want it fixed. Or they're referred by their general dentist who says, I don't know what to do now. This tissue's red all the time. Fix this. So those are situations you run into. And this is a picture right here that shows what it would look like if you looked at for orientation purposes. Here's the tooth and here's the root. And then this is right here is the sulcus, a normal sulcus. This is where you would be sticking your probe right here. Then here's your junctional epithelium. So it's on the enamel surface to the CEJ. And then you've got this little band here of connective tissue fibers before you get to your alveolar crest. So here this is equivalent to about 2 millimeters of space. So your junctional epithelium is about 1 millimeter and your connective tissue attachment right here, or your connective tissue fiber, 1 millimeter. So this is about 2 millimeters of space, and that's where the alveolar crest hits. Anybody have any questions on this? So this is just, these are just other illustrations. So this is again that same picture. So you've got your sulcus right here, and you've got your gingival margin, your junctional epithelium, your connective tissue. This is about 1 millimeter. This is about 1 millimeter. And so your biologic width is this area right here that's about 2 millimeters. This little indentation right here is your free gingival groove. And so here's the restoration they placed. And when you're placing the restoration correctly, you want the margin of the restoration to just like kind of tuck right behind that tissue. You don't want it all the way in the sulcus. You don't want it into the junctional epithelium or anything like that. You want the restoration to stop right there. But on the right, the picture on the right, same thing, only your restoration margin, they pushed all the way down. And so when they pushed this restoration all the way down, they've gone through the junctional epithelium and into the connective tissue. So now you have the restoration margin right here. You only have about 1 millimeter before the alveolar crest. So in time, the alveolar crest will resorb itself back 1 millimeter, and your tissue, your fibers will then have some breathing room. They won't feel squished anymore. Your junctional epithelium will move down here. So you'll probably have, because your junctional epithelium won't attach to the restoration, so it'll move down here and attach itself to the root. So you'll have a pocket there.
What other-
Faulty removable prosthesis. A removable prosthesis should be removed for cleaning and before going to bed. So you practiced in clinic on cleaning like removable partials and stuff, right? And dentures and things like that. Yes?
I haven't done that, but we've seen the process of it.
Okay, so you've seen the process of it. So patients should be advised to remove removable objects at nighttime before they go to bed. Now, that doesn't always happen. A lot of patients are very self-conscious. You know, nobody wants to go to bed without their teeth. And so oftentimes patients will leave their denture or their partial in all the time. They'll take it out, they'll brush it, and then they'll put it right back in. And so the only downside to doing that is it doesn't allow any breathing or break time for the tissues underneath those prostheses. So especially on a partial, if the clasp of the partial is going around your natural teeth and keeping plaque and biofilm attached to your tooth, taking it off, brushing the biofilm, and then putting it back in doesn't give it any time to kind of breathe. Damaged or poorly fitting removable prosthesis can impinge on gingival tissue and favor plaque accumulation, so keep that in mind. These are some pictures you can see. This partial, this is the clasp of the partial. These are the lower incisors, so they're replacing a premolar and some molars. And you can see this is poorly fitting and it's pushing down on this tissue and it's causing this fibroma right here. And so when you take it out, you can see here's the fibroma. It's also worn away or caused recession to this tooth. So causes of direct damage to the periodontium, food impaction would be one. So improper use of plaque control aids. Make sure when you give your patients oral hygiene aids, they know how to use them. And they know how to use them properly. Tongue thrusting, mouth breathing, traumatic toothbrushing, oral jewelry and body piercings, and trauma from occlusal forces, and parafunctional occlusal habits. So food impaction can strip gingival tissues away from the tooth surface and can lead to alterations in gingival contour, resulting in interdental areas difficult for patients to clean. So you can see right here, this patient has food stuck between these two restorations. This was an open contact. You can see these two teeth don't touch each other. Because teeth in occlusion are staggered like bricks, so each top tooth comes between two bottom teeth, and each bottom tooth comes up between two top teeth, staggering them. When you chew, if there's an open contact, the cusps from the opposite arch will push food down between the teeth and cause it to be impacted. That causes tooth decay pretty quickly. If you have something like this going on, it's just a matter of time before this decays underneath here. Decay under a crown usually leads to extraction. So it's close to 3 o'clock. Let's take a break till about 3:10, and then we'll finish this up. If you have any questions, feel free to ask questions.
Okay, I have one question.
Okay.
On the study guide, I know that you probably don't have it right in front of you, but there are like multiple things that I think could go with certain things. Like for number 4 on it, it says describe the local contributing factors that can lead to the direct damage of the periodontium. And I know we were just on that slide and it made sense, but then wouldn't like overhanging margin, the open margin, wouldn't that list of stuff qualify too?
Let me look at that. This is direct damage.
I mean, that says like exactly what the question's asking for, but I feel like the other slide, like all of that stuff would contribute to it as well.
Okay, let me see if I can get these to move. So you're asking like if things like overhang restorations and things like that can contribute to it.
Yes.
I think what the difference is, let me see if I can explain this. What the difference is causing direct damage to the periodontium. So the other things cause plaque accumulation.
But on the other slide, it said that tooth grooves and concavities, cervical enamel projections, it said those cause the plaque biofilm.
Yes, so they cause plaque biofilm to stick or to be difficult to remove, and the plaque biofilm causes the damage.
So that still doesn't make sense to me because there's still 3 lists for 2 answers is what I'm confused on. So where would the overhanging margins fit in then?
So overhanging margins would not be the direct damage. So overhanging margins, I guess the difference that I'm trying to explain is like an overhanging margin would cause plaque accumulation in the area because you can't access it with a toothbrush very well. But it's the plaque accumulation that causes the problem. If you have an overhanging margin and you can get, say, a water pick in there and keep it clean, it in itself isn't going to cause a problem. It's only that it's going to cause plaque accumulation and become a problem. Where these things directly are going to cause a problem, like food impaction, can cause, it can cause alterations to the gingival tissue in the way, like it'll pack down the interdental papilla and cause problems. The food directly will cause that. Like you don't have to have biofilm in the area, it's still going to cause a problem. The other one is caused by biofilm attraction. This is caused by directly.
Okay.
Does that make sense?
Kind of. There's just like another, like you have 2 lists that I'm just confused on where they go for the study guide, but I think I'm overthinking it maybe.
Yeah, I mean, it might make a little more sense after we get through this, but like when you take your toothbrush and you brush your teeth, like you probably have excellent home care, but you could still cause damage with your electric toothbrush, or not electric toothbrush, with your manual toothbrush by brushing too hard. But it has nothing to do with plaque biofilm.
Okay.
It's the toothbrush itself that's damaging your gum or your tooth structure. Where the other one, you can have an overhang restoration as long as you're keeping it clean, it can stay there forever and never cause a problem. What causes the problem is it allows biofilm in the area, and the biofilm causes the problem.
Okay. Yeah, I get it now.
Okay.
Okay, thank you.
You're welcome.
Professor Franklin. Sorry, I had my volume down. Can you hear me?
Yes, I can. Sorry, I had my mic off. I could hear you. I just had to get to the screen.
That's okay. That form that you just added for the initial periodontal assessment.
Yes, I haven't gone through that yet.
Okay, I just wondered, is that something we should print off and maybe stick in our clinic binder? Or
You can, yes, they're in the clinic too. There's a whole
okay,
folder of them in that big black box that sits on the front counter.
okay,
And so we'll do our first one in term 4, but every term just about you'll have to do one. So that's why they're in
okay.
the clinic. But you can print that one off to write notes on it. So like you know
Okay.
what goes in each section or stuff.
Okay.
We'll do that in a few minutes. I didn't know
Okay,
if anybody would notice I snuck that in there.
I get notifications for like everything, so I just saw it and wondered if I should print it.
Yeah. No, I know. It's like it drives us crazy because I guess you guys can turn off your notifications.
Oh, I didn't know that.
Yeah, we can't turn off your notifications, but you can. When we first went online with the other cohort, they got like hundreds of notifications because we were uploading all of our stuff like in one weekend. And so they were getting like all these notifications and stuff. And so we found out that they can turn them off. We can't turn them off, but you guys can.
Oh. So are we going over chapter 19 today too?
Yes, chapter 19 is very short.
Okay.
So since there isn't a study guide for chapter 19, will it be on our test?
It will be, but it's kind of an easier common sense one.
Okay. I just wanted to make sure. And on the initial response thing that you just sent us, that I think it was Jaylee that was just talking about it.
Uh-huh.
When did you say we would go over that?
We're going to go over that today.
Okay.
And there's that big black box on the counter in the clinic. They're in there under initial periodontal assessments. So you don't have to worry about like taking this one or treating this one special. They're in there because you'll do them for most of your classes down the road now. My dogs are outside barking like crazy. I'm just like, or my big dog's having eye surgery today. And so my husband just left to go pick him up from the vet and she's outside barking. I'm like, crazy.
I have a question about the assignment 4.
Uh-huh.
If that's okay.
Sure.
Okay, so I'm finishing it up right now, and at the beginning of the assignment, it says you will be rescheduling this patient for an adult prophylaxis, but will complete a thorough data check. So when we get down to like the patient needs part, would we just put adult prophy in there?
Mm-hmm.
Okay, and so her next visit would also be an adult prophy.
Yes.
Okay, I just wanted to make sure.
Yep.
Thank you.
She's a healthy person. All right. So how are your other classes going? You guys getting into the thick of histology?
Yeah, it's a lot.
That's a hard class.
Yeah, I agree. Today we went over like the periodontal ligament and some of the stuff we've already covered kind of in your class.
That's good. That is the nice thing about it, is it kind of crosses over in several areas.
Yeah, I thought the same thing.
Are the teeth back up?
Yeah.
Okay. Okay. So hopefully everybody's back. So direct damage to the periodontium. So these are things that cause damage to the periodontium without the assistance necessarily of plaque biofilm. So food impaction. Food impaction can cause a lot of trauma to the interdental papilla and the interdental areas of the teeth. You're going to have patients that you're going to clean their teeth, and they are going to have so much food packed between their teeth. And you'll sit there and wonder, like, how does this not bother them? Because it bothers you. Like, you're looking at all this food packed between their teeth, and it just gives you this icky feeling. So going over home care with the patient, reinforcing, flossing, and whatever you can get them to use between their teeth is about all you can do. But when you pull that meat out from between these two teeth, as you're stringing it away, it's going to actually be like shoved subgingivally as well. And so you'll pick out the little strands of meat that got under the gum, and then the papilla is going to be all like smooshed down and red and unhappy. And so it's good if you can show the patient what you're looking at. If you have an intraoral camera handy, that's great. If not, at least try to use a mirror and show them what this food is doing, and why it's so important that they clean it out. And usually it has a nasty smell and taste. Well, you'll smell the smell, they taste the taste. And so that kind of helps reinforce that this is like rotted meat between your teeth now. Then we've got your improper use of plaque biofilm control aids can result in direct damage to gingival tissues, causing alteration of the natural contours of the tissue. So you can see how this has been injured here. Patients oftentimes will use things that are not actual oral hygiene aids. I can't tell you how many patients pick at their teeth with paper clips, credit cards, bobby pins, push pins, or those push tack things. They will pick at their teeth with just about anything that fits. And so it's good to work with your patients on proper way to use those things, because they can like damage their. I remember a patient one time coming in. She was picking her teeth with like a staple. Like, she had straightened out a staple and was picking her teeth and accidentally got it stuck and couldn't get it out. And so she came in and we just numbed it up and took a scaler and picked it out. But people will pick their teeth with the most bizarre things, and they can cause trauma or damage to the gums from that. Your scalers, a lot of times patients will say, oh, I want to buy one of those scalers, or I bought something similar to that at Walmart. And I'm like, there's a reason they don't sell these sharp objects to go under your gum to people, or shouldn't be, because they're going to hurt themselves doing it. Tongue thrusting. So that's when a patient is swallowing, usually they will push their tongue against their anterior teeth as they're swallowing, and the lateral pressure, you can kind of see how their tongue is coming out from between their teeth here. That can cause trauma. Mouth breathing is a big one. Lots of people breathe through their mouth. Mouth breathers, though, oftentimes almost feel like insulted when you ask them if they breathe through their mouth. Because one of the big things you can tell if somebody's breathing through their mouth a lot of times is they snore. So if you say, do you snore, they get insulted. Probably because they've been picked on by their spouse or their boyfriend, girlfriend about snoring. And so when you say, like, do you find yourself snoring? It's the constant like sucking in of air dries the tissues out, and so they become irritated. Traumatic toothbrushing, we all know that we can damage our gums with a toothbrush. Causes gingival recession. If you are using either too much pressure or improper strokes. So you want to angle the toothbrush at a 45-degree angle toward the gum line. Use kind of circular motion, moving the toothbrush. Or if you have a patient that has gingival recession, they should be using an electric toothbrush. Now, I know not all patients can afford to buy an electric toothbrush, but there are some pretty inexpensive electric toothbrushes available out there too. And so you kind of gauge your patient, you get to know your patient and what they can and can't do. And if you find that they can't afford some of the fancier toothbrushes, then offer them the option of buying one of the less expensive toothbrushes. Dehiscence is something, and fenestration are two things that can happen as a result of abrasion. So if you look at this picture on the right here, dehiscence is where you have almost like the entire buccal bone is missing. So the root is showing. And then fenestration is where they call it this the door and this the window. So there's some bone here that keeps the tooth supported, but then you've got this like open window right here. And that's called a fenestration. So two terms you'll need to know. So excessive occlusal forces. There are different types of occlusal forces. You have functional occlusal forces and parafunctional. Functional occlusal forces are just exactly what they sound like. They're normal forces that happen during the act of chewing. Parafunctional occlusal forces are resolved from tooth-to-tooth contact when not in the act of chewing food or eating, such as clenching or bruxism. So parafunctional habits are ones that we can try and correct, like through an occlusal guard, a night guard when they're sleeping. Functional habits are not as easy to correct. They can exert excessive force on the teeth and to the periodontium. Trauma from occlusion is excessive occlusal forces that cause damage to the periodontium. So when you're looking at a patient and you see excessive, if you see bone, how am I going to try this? Vertical bone loss that's consistent on several teeth. So like the mesials of all of the lower right teeth have vertical bone loss. The patient has good home care. Patient has never shown a whole lot of periodontal issues or anything like that. So you kind of know it's probably caused by something else. Trauma from occlusion is probably what's going on. It manifests itself a lot of times in these vertical angular defects on multiple teeth. Tooth mobility is another one. So if patients have some tooth mobility and they don't have a lot of periodontal disease, that would cause that. Sensitivity to pressure. So patients come in and they tell you that their teeth hurt or are achy, and when they chew, their teeth are uncomfortable, but they can't really localize it to one tooth or not even one area. They just kind of say, well, they just kind of all hurt. That's usually not all their teeth are decaying or abscessing at once usually. Usually that's because they've been clenching, grinding, maybe they've eaten something that's caused, they had to they were torquing a bagel, pulling on their teeth, eating a bagel, and they've caused a little bit of trauma to the occlusion. And so they get sensitivity to pressure. Patients often, this isn't on the list, but a lot of patients will experience cold sensitivity when they've been clenching or grinding. Migration of teeth can start to move. Enlarged funnel-shaped PDL spaces. So you know how on a radiograph you follow the PDL space around the root of the tooth? So you've got the root and you've got the lamina dura, and in between it you've got that little PDL space. So you'll see an enlarged PDL space. So instead of the space being a tiny dark line, it'll be like a wider line, and it'll be wider at the top and get narrower because the tooth is rocking more at the top than it is at the apex. Think about when you wiggle a shovel in the ground, the bottom or the part of the shovel that's stuck in the ground might stay in the same place, but you're wiggling the top part and it's causing the top part of the circle to be bigger than the bottom. And alveolar bone resorption. So you can get bone resorption from trauma. Radiographic evidence, so you can kind of look at this and you've got loss of alveolar bone along the lateral surfaces on the center tooth. So see how wide these PDL spaces are compared to the teeth next to them. So this tooth is probably suffering some kind of occlusal trauma. There are two types of trauma from occlusion. You can have primary or secondary. Primary occlusal trauma is injury to the periodontium resulting from excessive occlusal forces. So secondary, though, is injury to the periodontium from normal occlusal forces applied to a periodontium previously damaged by periodontitis. So if you have, secondary occlusal trauma, it's a patient that has periodontitis. So primary occlusal trauma is excess force on normal healthy teeth. Secondary is normal force, but on compromised teeth. Do you need that explained further, or does that make sense? Anybody want it explained further?
I think it makes sense.
Okay. Other things that can cause primary occlusal trauma are high restorations. So those of you who work in general dentistry, occasionally the doctor places a restoration and the patient kind of plays around with it and says, it feels like I'm biting higher on this side. And so you grind it down a little bit and you send them on their way. And they go home and it's still grinding a little high or feeling a little high, but they don't want to go back. They just came from the dentist. They don't have time to go back. So they just keep using the restoration as it is. And so those teeth are hitting harder because they're hitting that restoration first. So by the time the other side reaches occlusion, they've crunched down pretty hard on this side. And so that can cause occlusal trauma. Teeth, when you're missing teeth. Anytime you're missing teeth, your occlusion is no longer balanced, and so the remaining teeth have to take more occlusal force. As far as secondary occlusal trauma may result in rapid bone loss and pocket formation. So that's the normal amount of occlusal force, but you've got compromised teeth. So you've got bone loss on molars, and just the regular chewing is causing problems. And you can have lateral occlusal forces. So tipping of the tooth within the socket due to lateral occlusal forces. So this picture on the left, I don't know if you can see this P and this T down here, but if the occlusion is not balanced, let's say in the case of crossbite, oftentimes the occlusion, the teeth are coming down where they shouldn't. they're pushing that tooth in a different direction. The tooth is being pushed this way. It's causing pressure to the bone right here instead of evenly distributed. And so this bone is going to resorb. And that's when I said how you can get vertical defects, that's commonly how you'll get vertical defects. So this bone right here will resorb so that to accommodate this tooth being pushed this way all the time, causing a vertical defect. Because it's not going to resorb this way across, it's going to resorb down this way like this. Damage to teeth with reduced bone height. This is an easy one you can see. The alveolar bone is 2/3 of the way gone, 3/4 of the way gone. So here's your tissue support. You can see how these periodontal ligaments are stretched on one side and they're compressed on this side from the, and here it's leaning against the bone, so it's kind of squishing this side right here. This will cause more bone resorption. So that's it for that. Does anybody have any questions on that? Okay, now let's go for this tricky part of seeing if I can get the next one open. Any chance we can see that?
Yeah, we can.
Oh, good. It's my lucky day. So this is a pretty short chapter. We're going to talk about tobacco, smoking, and periodontal disease, and just specifically tobacco, or smoking, I should say, as a risk factor. None of the other risk factors, just this one. Tobacco, smoking, all has such a tremendous impact on periodontal disease, so we hit it pretty hard. Our old textbook had like 2 little paragraphs about it, and so we pretty much had to make the rest of it up as we went, and you had to figure the rest of it out in clinic, and I just don't think that did a lot for the students. It took all the way till term 6 or 7 to try and understand the impact that tobacco and smoking have on the disease, because we just didn't talk about it very much because it wasn't in the book. So I love the fact that this book dedicates a whole chapter to it, even if it is a short chapter. The epidemiology of tobacco in periodontal patients. Cigarette smoking is a very strong risk factor for periodontal disease. Cigar and pipe smoking are significant risk factors for attachment loss, and smokeless tobacco is associated with severe recession and loss of buccal attachment where the plug is placed. Cigar, cigarette, and pipe smoking are very similar in their attachment losses and things like that. Pipe smoking and cigar smoking are horrible, horrible stains to try to clean off. Any of you who have tried to polish cigarette smoking, cigarette stain, cigar and pipe are like 10 times harder. So they're just an awful thing. Usually you have to use a Cavitron to clean it off. Smokeless tobacco, on the other hand, just causes tissue modifications in the area where the tobacco is being held. So the first thing you want to do is preach to your patients about quitting their habit. But if they're not interested, they're not interested. And so if they use smokeless tobacco, the second best thing to do is have them move it around to different parts of their mouth. Because every time they place the tobacco, it causes some change to the tissue that it's butted up against. And so if they leave it in the same place, it's going to continue to cause changes to that same tissue. If they move it around, then it moves around the tissue alterations, but it allows time for spot number 1 to heal before the tobacco ends up back over there again. Smokers are 2 to 3 times more at risk for periodontal disease. They are likely to lose more teeth than non-smokers. They're likely to exhibit attachment loss and periodontal destruction more likely than former smokers and never smokers. Smoking may be responsible for about 50% of cases of periodontal disease among adults in the United States. And they're considered heavy smokers if they smoke more than 10 cigarettes or a half a pack a day. And you'll notice when you're in clinic and you look at your staging and grading chart and you get to the grading part where it talks about cigarettes, it divides it by 10 cigarettes a day, less than 10 cigarettes, or 10 and more. More than 4,000 toxins are present in cigarette smoke. You don't have to memorize the toxins. Oral problems with smoking. Smoking causes halitosis or bad breath, dry mouth, dental staining, periodontal disease, and then worst case scenario, cancer. Heavy staining and biofilm accumulation. This is what it looks like. This is what this upper left one is like what cigar smoking looks like. Now you can imagine you definitely need to use a Cavitron to get that stuff off. If you look down here on the lower right where the radiograph is, see how all the bone is eaten away. Of course, this patient has calculus too, lots of calculus. So that's definitely not helping their case. But see how much bone they've lost. The effects of smoking on the periodontium, it has an impact on oral microbial biofilms. It has an impact on the immune system, and it has an impact on bone metabolism. So how does it affect biofilm? We kind of touched on this already, but plaque biofilm may be colonized with more potential periodontal pathogens like P. gingivalis. It gives a favorable environment for the growth of anaerobic bacteria in the pockets. So I put that in bold because that's what you're going to talk to your patients about when you lead into the conversation. Not specifically in those words because they won't know what the growth of anaerobic bacteria in the pockets really means. But basically explaining to them that good bacteria in your mouth need to have oxygen to survive. The bad bacteria survives just fine without oxygen. When you cut off the oxygen supply by smoking, you're allowing an environment for the bad bacteria to keep growing where the good bacteria can't. That's kind of pretty simple of how I summed it all up. Impact of smoking on the immune system. It affects the inflammatory response. So it impairs neutrophil function. So it does suppress the immune system to an extent. Smokers do have more issues with colds and infections and things like that because their immune system is not quite as strong as a non-smoker. As far as bone metabolism, it's associated with a greater amount of alveolar bone destruction. Nicotine suppresses osteoblasts. It increases the secretion of one of your interleukins, and it may alter normal bone remodeling. So nicotine is the bad boy in this one. Environmental tobacco smoke. This is an area that's being studied more and more. It's more like a public health kind of study. It is generally accepted that even non-smoking individuals are affected by inhaling secondhand smoke or passive smoking. Data concluded that odds of having periodontitis are 2 times higher for those exposed to passive smoke than somebody who, not than the smoker, but than somebody who is not exposed to passive smoke. They should have clarified that a little bit. E-cigarettes have become much more popular. They don't contain tobacco, so it's a liquid nicotine. I'm not that familiar with e-cigarettes myself, but I do know that they have have nicotine, not tobacco, and the nicotine causes the problem. As we talked about up here, nicotine suppresses the osteoblasts. Osteoblasts build bone or are bone building cells, so we suppress them. And so that's kind of the bad part to all of that. let's see, and water pipe smoking. I'm not real familiar with hookahs myself either, but some of you may be more familiar with some of these things. Has a significant impact on the oral cavity, has a significant amount of nicotine, and 27 known carcinogens. So if anybody out there is using the hookahs, keep this in mind. Associated with an increase in periodontal pocket depths, loss of clinical attachment, and bone loss. Smokeless tobacco, this would be like your chew stuff, results in an increased inflammatory response in the tissues. So where you put the smokeless tobacco, you're going to have an increase in inflammatory cells. And then effects on smoking, on periodontal therapy, chemical products and toxins in tobacco smoke may delay wound healing. That's the most important thing to know, is when you have a patient who smokes, any treatment that you do on them, they are not going to heal the same way. They're not going to heal as fast, first of all, but they may not heal at all. Smoking has a negative effect on fibroblasts and collagen production. So remember your fibers, all of your connective tissue. And then smokers have less reduction in probing depths. In other words, their probing depths stay deeper longer. And they gain less clinical attachment after treatment. So if you have a patient that smokes, we had some smokers. Over the years, I had so many smokers. They have no interest in quitting smoking. They're heavy smokers and have smoked for a long time. They come in and a lot of times they have what they call a smoker's cough. And many of you may have heard it before, especially if you've worked on patients in clinic or in private practices that have it, but it's kind of like this raspy, rattly cough that they get. And so patients like that, you can do scaling and replaning on them. They're not going to bleed. Probably not at all usually. Their tissue's very white and fibrotic, and they don't get the pocket reduction. So if they have 7 millimeter pockets, they're probably going to get 6 millimeter pockets. Maybe 5s, but probably not less than that. So the main thing you're trying to do with those patients is keep the disease from progressing at a rapid rate. You know the disease is going to progress, and you know that it's going to progress rapidly. What you're trying to do is make it less rapid. Help them keep their teeth longer. Smoking and peri-implant disease. So smoking affects peri-implant tissues. We talked about peri-implant mucositis and peri-implantitis. Peri-implant mucositis is like gingivitis. It's soft tissue related. Peri-implantitis affects the deeper structures like the alveolar bone. Most of the time in the offices I've worked in, we wouldn't even place an implant on a patient that smokes. For one, their healing is going to be slow. 2, they usually have existing periodontitis, and so that's going to decrease the success rate of the implant. They also are at a rapid rate for continuing to lose support. So you could place the implant and it could stay healthy for a little while, but it's probably not going to last very long. This is a picture of peri-implantitis. So what do we do with our smokers? We try to get them to quit. So there's lots of different ways you can try and get your patients to quit. You're usually going to sort of tiptoe around these patients so that you can discuss the topic, but at the same time you kind of get a feeling or a vibe of where you know your patients are. Oftentimes they're not the first person to talk about smoking. Their medical doctor has already preached them. Their spouse or their loved ones have already preached to them. They know what they're doing to themselves, but yet it's an addiction. And for some people, I mean, we make it seem like it's so easy. Well, you don't like doing it, just quit. But it is an addiction. And so we have to keep that in mind when we're working with smokers. They can't always control this addiction. It's a very strong and powerful one too. So baby steps are good. Be a good support system for them. Don't make them feel like if they quit smoking and then they start up again, let's just try to work on turning this back around, you know, that kind of thing. Current smokers have worse periodontal conditions than never smokers or former smokers. What you'll see with former smokers is they have periodontal destruction, but it's stopped. So most of the time on your former smokers, depending on how long they smoked and how much destruction they had, you're not, obviously the bone loss is not going to come back. Their tissue, soft tissues will turn around, like the blood flow and all that, but you're not going to get the alveolar bone back. But what you're hoping for is to just stop the destruction where it is and keep them maintained that way. Treatment outcomes in former smokers are like never smokers and better than current smokers. Benefits of smoking cessation or stopping your smoking on the periodontium result from reduction in pathogenic bacteria. So in other words, as soon as the blood supply comes back, it brings oxygen to the area. Good bacteria can survive again. So it hopefully returns balance in the bacterial colonies. Usually if the patient quits smoking, we would wait a certain period of time to see if they're going to be successful. And then you're going to do scaling and root planing again, because now you want to try and change the bacteria. You want to try and eliminate some of the more powerful bacteria and allow those healthy bacteria to grow back, because now they have their oxygen and their blood supply and everything back. And it also improves the host's immune inflammatory response. So smoking cessation counseling, the World Health Organization advocates that all health providers must be involved in tobacco cessation efforts, including oral health professionals who reach a large proportion of the healthy population. Dental hygienists have a professional responsibility to provide tobacco cessation services as a routine component of dental hygiene practice. So it is your responsibility to work with patients who smoke to try and get them to quit. There's always that fine line. You start laying the groundwork and you realize when to stop. Because like I said, for most of your smokers, if not all of them, they've heard this before. You're not telling them anything they haven't already heard. And so sometimes they get short with you. Sometimes they get annoyed with you. That's when you know it's time to say, hey, I'm just throwing this out there. If you want additional information, you know where you can find me. They go home and they think about it. Sometimes you have success, sometimes you don't. So key elements in providing advice: establish tobacco use status for all patients at regular intervals. Advise of the value of stopping and health risks of continuing. Highlight dangers of tobacco use and advise of support of quit lines. So I would say you are to always document in your record how much the patient is smoking. This is an area where students fall. So be the first cohort to actually be on it, okay? When you look at your patient's medical history, the smoking tobacco habits in the far right column. It's almost to the bottom. So make sure you look at the far right column, almost to the bottom where it says tobacco habit, and address that. If they checked it off that they smoke, or if they check it off that they have a tobacco habit, find out first what tobacco habit do they have. Smoking, chewing, whatever. And then find out how much, how often. And you should do that at every appointment. You should be your patient's cheerleader. If they're cutting back, good job. Advise them on the value of stopping and the health risks of continuing. So as you're going through and you're measuring their pockets, If you're starting to see some changes, tie that in. Patients a lot of times are in denial. I was going to lose my teeth anyway. No, you're going to lose your teeth because you smoke. No, I was going to lose my teeth because my parents they lost their teeth. They have terrible teeth. No, I think your smoking is really putting your teeth and your gums at risk. Well, no, it's because of my parents. No, it's because you smoke. You know, I mean, you got to kind of work on getting them adjusted to the idea because they're in total denial most of the time. So sometimes, you know, I said baby steps. Sometimes you have to kind of work slowly at it. Other patients come in and they're ready. They don't want to lose their teeth. They're ready. So everybody's different. Anybody have any questions about smoking and tobacco? You guys probably as a younger generation know more about some of these other things